Hello, everyone, and welcome to today's webinar. And I'm excited about this webinar because we're highlighting what was an incredible conference in DC last month. And we really wanted to go through and give you all, those of you especially who weren't able to attend, a taste of what was discussed at that meeting. We have a lot to cover, a lot. And so we will probably not be able to get to Q&A. If we have a little time, we'll discuss a few points of that come up. If you do have questions, go ahead and put them in the Q&A, and one of our folks will hopefully be able to address them in the chat. But we won't be able to probably discuss them, just so you know, because we have a lot to cover. So we're going to get going here, I have today the other members here of the webinar committee. I have myself, Arthur Allen, a clinical pharmacy specialist, anticoagulation and program manager at the VA hospital in Salt Lake City. We have Gene Connors, the medical director of the hemostatic and antithrombotic stewardship medical director of the anticoagulation management services hematology division at Brigham and Women's. We have Jori May, assistant professor, Department of Medicine, Division of Hematology Oncology, University of Alabama at Birmingham. And we have Naomi Yates, manager in clinical pharmacy of the Clinical Pharmacy Services Outpatient Pharmacy at Kaiser Permanente in Georgia. And we are going to get going. So I'm going to hand it over to Naomi for the first section. Naomi, take it away.
All right, thanks, Arthur. I'm really excited to be able to highlight the sessions for you from our conference. For those of you who are not able to attend, I'm going to cover first Allison Burnett. She gave us a little overview of the state of our AC forum and then talked about cultivating anticoagulation stewardship. That was followed by Leslie Lake, who continued on stewardship to address inspiring legislative change. And then we had Tracy Minicello and Mike Strife covering top papers you need to know. So Allison kicked things off for us to give us a little bit of an update of what had been going on in the area of anticoagulation stewardship. We had our Anticoagulation Stewardship Summit with 25 key stakeholders who discussed the need for system-level improvements in thrombosis-related care. She highlighted the work of the Stewardship Coalition, global adoption to expand our reach, and research and publications as well in anticoagulation stewardship. Key stewardship takeaways from Allison were to remember to identify and align your antithrombosis stewardship opportunities with the needs of administration leadership in order to be more strategic and secure support. She reminded us to use a stepwise approach to stewardship initiatives to ensure a strong foundation. Make sure you right-size your initiatives. Don't try to boil the entire ocean. Consider a small-scale pilot at first to get early wins and to generate support from administration. And then Leslie Lake highlighted some of the work Stop the Clot has been doing, including the Stop the Clot bus tour and their work to meet with impactful legislators. She reminded us to identify your champions and work together, try to rally the community, and think outside the box. Okay, that brings us to our top papers. And this is just a tiny little glimpse of what Tracy Minicello and Mike Strife covered for us. They did begin with a patient case to help you to understand the different articles that they were trying to highlight. So we had a 76-year-old man with hypertension who had been on warfarin for 5 years for AFib, and he asks you whether he should switch to one of the newer agents he heard about on TV. So you look at his time in therapeutic range, you see that it's about 60%. His medications and labs are listed here. And the question is whether you should switch him to a DOAC, and if so, which one should we consider for this patient? You might be surprised by the findings. So the first article they highlighted was Frail AF. So this was an older patient, 75 or older, living with AFib and frailty. Those, of course, excluded patients with reduced renal function or valvular AFib. This was a multi-center superiority open label randomized controlled trial and about 1,300 patients. It actually ended up, they stopped the trial early because they found that switching patients from vitamin K antagonist to a DOAC in frail older patients with AFib was actually associated with more bleeding compared to continuing the vitamin K antagonist treatment. This was even with apixaban and even with good TTR at 65 to 74%. This was without an associated reduction in thromboembolic complications. Okay, the next paper they highlighted was a study that was done looking at diltiazem use with rivaroxaban or apixaban. This was in Medicare beneficiaries aged 65 or older with AFib who took apixaban or rivaroxaban and then began treatment with diltiazem or metoprolol. Total patient count was about 204,000. We had 53,000 in the diltiazem group, 150,000 in our metoprolol group. This was a retrospective cohort study, and what they found was that in this patient group, diltiazem was associated with a greater risk of bleeding than metoprolol, especially for patients on that higher dose of greater than 120 milligrams per day. So that's, as you can see here on the left, is the patients who were taking less than or equal to 120 milligrams per day. And then on the right is patients who had greater than 120 milligrams per day. So you can see that there's a larger gap here between the diltiazem and metoprolol group for the patients who are on the right, taking more than 120 milligrams per day. Okay, next thing was to look at rivaroxaban versus other oral anticoagulants in older adults with AFib. So starting with rivaroxaban versus warfarin, we did see higher major bleeding and GI bleeding, but lower intracranial hemorrhage and lower risk of systemic embolism, and no difference in ischemic stroke. For rivaroxaban versus dabigatran, we did see also higher major bleeding, but no difference in GI bleeding or intracranial hemorrhage, and no difference in ischemic stroke or systemic embolism. And then for rivaroxaban versus apixaban, we saw higher risk of major bleeding, GI bleeding, and intracranial hemorrhage, along with an increased risk of stroke. We've got the references here on the bottom if you wanted to take a look at that at a later time. Okay. So very quickly, I can highlight for you what was covered for anticoagulation use in older adults, patients with falls, cognitively impaired, or patients at end of life. So for anticoagulation in older adults, we found that use of rivaroxaban was associated with a significantly increased risk of ischemic stroke and systemic embolism compared with apixaban, and an increased risk of bleeding compared with warfarin, dabigatran, and apixaban. In our older adults with falls and an anticoagulation naive population, 65 years or older with AFib, falls did not increase the risk of bleeding. This was very important. This is very similar to what we're seeing with warfarin, which you can take a look too at that article. In cognitively impaired, this was kind of a surprise to me at least. To prevent one stroke, 3.7 patients would have to suffer major bleeding and 1.7 patients would die. Anticoagulation end of life. So for anticoagulation end of life, you really need to consider the time to benefit versus harm. For venous thromboembolism, it takes a very short time to see the benefit. So maybe you would continue anticoagulation for that patient if their life expectancy was longer than how long it would take to see the benefit of treating that venous thromboembolism. For AFib, it may take longer to see that benefit. So in that patient, you would need to have a shared discussion, but maybe consider discontinuing the anticoagulant depending on life expectancy again. For anticoagulation itself, it doesn't take long to see harm from anticoagulation itself. So that was something to consider for anticoagulation at end of life. Okay, Rinove, reduced versus full dose DOAC. I know this comes up quite a bit for high risk recurrence VTE. The population was ambulatory patients aged 18 or older with acute symptomatic VTE who had received at least 6 months of uninterrupted therapy of full dose anticoagulation for whom extended anticoagulation had been indicated. Sample size was about 2,700. This was a non-inferiority, multi-centered, randomized open label trial. The results were that recurrent VTE occurred in 19 of the 1,383 patients in the reduced dose group versus 15 out of 1,385 in the full dose group. The non-inferiority criteria was not met, meaning there were similar amounts of occurrences of venous thromboembolism in both groups, but there was substantial reduction of clinically relevant bleeding with the reduced dose. In a subgroup, when we're looking at BMI of greater than 30, that might be a population where you might consider not reducing the dose, because we did see more VTEs in that patient group. So here you can see, I just wanted to show the graphs for you guys. In the graph on the top, we've got cumulative incidence of symptomatic recurrent VTE, our primary incomes. You can see that there was no difference there in the rates of thromboembolism. For B, our cumulative incidence of major and clinically relevant non-major bleeding. The first secondary outcome, you can see that there was a difference here. So we did see a reduction in bleeding in those patients on the reduced dose. Okay, next section is common conundrums. This was Jeff Barnes looking at AFib, whether are we doing a great job with treating our patients with AFib. I did a presentation on practical considerations to improve patient adherence, and Scott Yates did for us patients that keep me up at night, my anticoagulation nightmares. Okay, so and can you show, there's animation, I believe. Thank you. So this graph is just showing us the amount of patients who are not treated with oral anticoagulation. It varies a little bit. And we know there are some disparities here according to race, but approximately 60% of patients are untreated who have AFib and have a reason to be taking an anticoagulant. You can go to the next slide. Who should be taking the anticoagulant? Well, definitely the patients in this green area. So if they have greater than or equal to a 2% risk per year, so that's our CHAD score of 2 to 6 or CHADS VASC of 4 to 8. Patients where it could be reasonable to treat are patients who have 1 to 2% risk per year. So that's our patients here in the yellow, your CHAD score of 1 or CHADS VASC of 2 to 3. So Jeff highlighted for us a few different studies that were done to show the impact of real-time alerts to increase prescribing. We did see a good increase for the AF Alert 2 study and the Durham VA study. The AF Alert study showed about a two times increase in oral anticoagulant use. The Durham VA study was able to demonstrate about a 50% increase in the oral anticoagulant use. In the Support AF2 study, there was no increase seen in the use of oral anticoagulants. Reasons for not starting, go back for me, thank you. Reasons for not starting the oral anticoagulant were numerous. You can see here the different reasons. Sometimes they're considering the bleed risk and they think the bleed risk is too high, the fall risk is too high. Maybe they're in AFib sometimes, not in AFib some of the times, or they have low stroke risk, that sort of thing. Jeff highlighted for us to consider the clinician and the specialty when you're looking at what kind of alerts to use. What is the best place for this type of alert? Is it in a specialty clinic like cardiology, or is it in outpatient, for example? Okay. That brings us to my presentation. This is a very, very abridged version, but basically I wanted to highlight some different avenues that you could take to address these different types of barriers. So financial barriers, you could consider what resources you have in the patient's family members, caregivers, social work, financial counselors, manufacturers, sites. You may be able to prescribe larger quantities, or there may be mail order discounts that can be offered. For psychological barriers, it is really important to try to build that trust with the patient. And there have been studies shown that demonstrate that targeted education at the specific area where the patient is misunderstanding can help to improve adherence. We need to make sure that the material that we're providing to our patients are at the appropriate literacy level and preferred learning style and language. And then in terms of access, we could be creative as well, tap into our resources like social work or community transportation resources to help for patients who are not able to access the medical center. I reminded everyone of some techniques that we could use to help to build trust with that patient. Even if they say no the first time, that's okay. They may be able, sorry. Even if they say no the first time, it's okay. You can help to build that trust over time. You can offer the patient a fresh start to try again. Here are some examples of some words that you can use to demonstrate empathy with the patient. So something like that sounds like a tough situation. I appreciate you for sharing this information with me. The services are here if you ever need them. And then rather than terms like social health or barriers or issues, these are not exactly patient-friendly terms. They don't help to build trust. What can help is to change your language into something like whole health or challenges or service. This is a service here for you. I wanted to remind you guys of the rapid resource that is available on the website. It has a clinician tool there, a one-page tool that you can take with you into the clinic with the patient to remind you of some resources that you could try based on the different barrier that the patient is reporting. This brings us to Scott Katz's presentation on patients that keep me up at night. You might be surprised about this too. So he covered for us patients with AFib or VTE undergoing PCI. You very rarely need triple therapy with these types of patients. If dual therapy is needed, he encouraged us to change the aspirin to clopidogrel, meaning that you've got your dual therapy with your anticoagulant and your P2Y12 inhibitor. For non-cardiac surgery, in patients with prior PCI, where oral anticoagulation monotherapy might be discontinued before surgery, you might consider substituting the aspirin until the oral anticoagulant, substituting with aspirin until the oral anticoagulant can be safely reinitiated. For antiphospholipid antibody syndrome, the editorial suggests not using a DOAC for any portion, triple, double, or single positive. And then remember not to test for lupus anticoagulant during anticoagulation treatment. You can test for anticardiolipin or beta-2 glycoprotein 1 antibody while the patient is on an anticoagulant. There was a study done looking at off-label DOAC dosing in AFib. So Scott reminded us that off-label dosing, high or low, can increase mortality. And I think that brings us to Jean to cover new and improved for us.
Thanks, Naomi, and thanks everyone for being here this afternoon. So, new and improved, keeping anticoagulation clinics relevant by Andrea Van Beek was an excellent discussion. As you can see from this slide, when we look on the far left, we start with drug management. Those are the thrombosis services of the past, where all we did was manage drug. If you follow this roadmap, you can see that there are a lot more activities that these services, or we feel at AC Forum, that thrombosis services should engage in to take the best care of our patients with thrombosis. And so when you get to the end of this roadmap and incorporate many or some or all of these factors, we will actually have a thrombosis disease state management service and not just a drug management service. Next slide, please. So Andrea presented a cookbook of ideas to expand your practice, and I would ask that you look for her information on our website. Not only do you need to manage DOACs as a drug, but you can use population health management tools to identify outliers who might need more attention. VTE care, I'm going to discuss in the next presentation. Atrial fibrillation, we all know that undertreated AFib patients with undertreated AFib are a problem. And then a lot of the work that my staff do up here with our almost 4,500 patients between the Brigham and the Dana-Farber Anticoag Management Services are peri-procedural management. We have patients doing warfarin patient self-management where they actually adjust their own dose, sometimes with the advice of one of our staff. And then some clinics have evolved to include cardiovascular event prevention and management, preventing the next stroke or MI. And I think one of the biggest roles that thrombosis clinics and stewardship programs of the future can engage in are care transitions from the inpatient hospital to the rehab center to the outpatient care. Next slide. So, speaking about care services, Yusuf Basada engaged in discussing novel VTE care models. And he points to 3 papers listed here that shows that we need improved anticoagulation stewardship to minimize avoidable negative situations. And in these cases, a lot of the problems came from patient lack of adherence to assigned drug, and that led to complications. Next slide, please. And so he suggested that these are 3 components of the solution: following, triaging, and monitoring our patients with VTE at each point of contact to help with their management. Next slide. And so you can see this roadmap for starting with when patient was identified with VTE and triaging them in the appropriate direction, initiate therapy, and monitor with multiple steps along the way with a dedicated anticoag team, communication with all the providers involved with patient care these days, and follow these patients longitudinally. Do not just write the DOAC prescription and never see the patient again. And this is what he calls precise patient management. Now, Jeff Barnes discussed factor 11 inhibitors, and I've included a lot of his slides here. Please go through, there's some animation here. I would refer you to a couple of different reviews that he has on his slides. One is in Blood, but Jeff himself wrote a review that appears in Journal of Thrombosis Hemostasis. Right now, we're going to look at 3 approaches to decrease factor 11 activity in patients: antisense oligonucleotides, which prevent production of factor 11, monoclonal antibodies, which bind to factor 11 and prevent it from working, and small molecule inhibitors. These are just like the DOACs. Next slide. And so there was a big deal made about phase 2 studies in patients who have knee arthroplasty and how good or how well does the individual factor 11 inhibitor work to prevent VTE, and how well does it decrease bleeding compared to enoxaparin. Please advance. And so all of the ones that you're seeing did dose finding studies, sometimes 10-fold differences, 8-fold, 5 different doses in these knee arthroplasty studies. But if you advance, please, Arthur. There was not a dose finding study for asundexian. Please move forward. So, and advance again, sorry, there's animation here. And so what you can see from the Azalea-Timmy study, which was the monoclonal abelacimab, that this was stopped early because of reduction in major bleeding that was roughly 60%. This was huge, okay, compared to rivaroxaban in patients with atrial fibrillation. Periprocedural bleeding events were also extremely low, and despite no treatment, no reversal agents, although there were strategies discussed in these trials, patients on abelacimab had fewer bleeding events with procedures than those on rivaroxaban. Next. This trial gets a lot of press because it too was stopped early by the Data Safety Monitoring Board, the Oceanic AF trial. However, for the opposite reason that the abelacimab trial was stopped. And in this trial, asundexian was inferior to apixaban for preventing stroke at 6 months and out further. I would caution you to read the trial itself and to read some of the reviews out there, including that by Jeff's. Most of us feel that the dose of asundexian that was selected for this trial was insufficient. It was low. So more to come on that in the future with regard to seeing this drug. So this is a list of the ongoing phase 3 trials, the monoclonal abelacimab, the oral small molecule milvexian is still going on, as is one of the asundexian trials. So stay tuned to AC Forum. We're going to be bringing you a webinar in June or July regarding the factor 11 inhibitors themselves. Next slide. Benood Bigdeli, a colleague of mine here in Boston, discussed complexities in valve management. This is the outline. I will tell you there's a lot of complexity here, and I suggest you read some of the work in this area. Next slide. Basically, these are Benud's practice considerations despite no high quality evidence. Most guidelines and most clinicians consider bridging anticoagulation. But given the different flow patterns in the mitral position, despite limits in available evidence, it's reasonable to assume that there is an increased risk of embolic events without, and even in some patients with, anticoag in the mitral position. So mitral positioned valves, you must really be careful about managing their anticoagulation around procedures. Short-term interruption with the modern valves, like the Onyx valve, has a decreased absolute risk. And if you need to stop because of active bleeding, then you can listen to the valve and see how well it's working. And you may want to do serial ultrasounds to check that the valve gradient has not changed due to clot. Next slide. So in summary, the greatest risk of stroke and systemic embolism is with mechanical valves that are usually older valves. And we still see these patients. They've got 15-year-old valves. They're still going along. We think the valve's been in place for a long time, but they actually make us nervous about risk of clot. Use of aspirin paired with anticoagulation is not necessary in most patients unless they have a need for aspirin outside of the valve. And for patients undergoing TAVR, single antiplatelet therapy is the best. Next. So now we're going to discuss entering the gray zone. And in this section, we're going to talk about areas where there's no clear right or wrong in many situations. And so the first section is thrombophilia testing that I presented on. And Damon, unfortunately, was hampered by travel plans and weather. So thrombophilia testing, there's still a lot of controversy about who should be tested, and the reasons are listed here. No high quality data that results of testing really should affect your care, and there's a misunderstanding of how to use the results. We test, we find a positive result, we keep people on indefinite anticoagulation, even if they don't need it, or the converse. So a lot of thought needs to go into who you're testing. The one caveat that we all agree on is that please do not test while an inpatient or in the emergency department, because what's going on with the patient at that time can affect your results. Next slide. So these are the factors that I consider important for testing a patient. Personal history of VTE. Is it somebody young who's sitting in front of you with a clot? Age that they develop the clot, the younger you are, the harder it is to provoke a clot. Family history, similarly, lots of family members with clot sort of points to an inherited thrombophilia. However, it can't be grandma who had a stroke at age 85. It has to be a family member who had a clot under the age of 50. And the biggest question, or the biggest factor that you need to consider, is what will you actually do with the results? Will it change your management? So ASH has created testing algorithms for patients with VTE, which appears in this slide, and Damon made this slide. And you can see it's color-coded for red, do not test, green, yes, and then yellow, well, maybe. And you can see that in the bottom right-hand corner, all of the advice is conditional and with low certainty of evidence. So if you have a patient with a VTE, check those green boxes. Here, in this situation, the one thing we want to highlight, and we don't always agree with some of ASH's guideline results, those of us in the field, just saying. But if your patient does not have VTE, there's a lot of red on this slide. There's a lot of yellow. The role of testing in people who've never had a clot is not clear, with the exception of Q15 right in the middle of the slide, COC, which is should you test before starting a patient on combination oral contraceptives? And the answer is absolutely no, in red. Do not test. Next slide, please. And so if you have questions about this, the AC Forum came out with a new 2-page rapid resource on thrombophilia testing. We released it March 13th, just about 2 months ago. So please take a look at this. It is very comprehensive and it lists all the resources for you. Next slide. The next session is going to talk about APS challenges, and Shruti Chaturvedi from Hopkins and Annika Sanegra from Mayo Clinic teamed up. These are the new ACR, American College of Rheumatology, and European Union Against Rheumatism. And actually, Damon's made this slide. But this shows you the clinical factors that can accumulate points in the top two rows here. VTE, arterial events, microvascular events, cardiac valves. And then in the gold at the bottom, the new points assigned for laboratory criteria. So if you go to the next slide and you count up points for your patient in the clinical domain, represented here in the red, and the laboratory domain in the gold, you can then have greater certainty and more granularity than past criteria for does your patient have antiphospholipid syndrome or not. Now, the caveat is that not every patient is going to fit this algorithm very well. And this algorithm was designed for research purposes so that when you're running a clinical trial, you have patients with the same characteristics. So clinical judgment always is important. But in order to even think that your patient has antiphospholipid syndrome or diagnose them with antiphospholipid syndrome, they must have 3 points from the clinical domain and 3 points from the laboratory domain. Next slide, please. And so this, and if you can advance, there are 2 boxes that show on this window. And we all know, I think, and this was presented earlier in this presentation, that in meta-analyses of studies of DOAC versus VKA in patients with antiphospholipid syndrome, that there's a higher risk of recurrent events, particularly arterial thrombotic events, in those treated with DOAC compared to warfarin. So if you have a patient with an arterial event in antiphospholipid syndrome, please use VKA. Next slide. Now, and if you click a couple of times, you'll see that we have adjunctive treatments for patients who have APS that may also play a role in decreasing the thrombotic risk. And these are shown here, and it's also published in Blood Reviews in 2017 by Shruti and others. And one more click. So you can see that rituximab, hydroxychloroquine, or Plaquenil, and statins may all play a role in decreasing inflammation, decreasing hyperreactivity of cells, and therefore decreasing thrombosis. Next slide. Oh, and eculizumab, yes. And this is a nice flow chart, which you can refer to in the journal Blood, that leads you down pathways about what to do if your patient with antiphospholipid syndrome has a thrombotic event despite adequate anticoagulation with vitamin K antagonist with a target range of 2.5 or even 3.5 and low dose aspirin. So I would point you in the direction of this because this is very helpful. This is analogous what we do in patients with cancer who have breakthrough thrombosis. Next slide. Yes, and these are other things you can consider to confirm that your patient really failed the warfarin. Next slide. And so in this section of the session, there were 2 speakers discussing DOAC reversal with a spotlight on factor 10A inhibitors and DOAC reversal part 2, 4-factor PCC and future reversal drugs. So in the following few slides, Deb Siegel from Canada discussed that despite how wonderful DOACs are, we still have bleeding rates in patients. Major bleeding events, 2% to 4% per year, depending on the population, and clinically relevant non-major bleeding even higher. And when we look at the DOACs versus VKA, although most of the DOACs and in a meta-analysis that Christian Ruff did, have a 50% reduction in intracranial bleeding and a 14 to 40% decrease in major bleeding, there's actually an increase in GI tract bleeding with DOACs compared to VKA. Next slide. And so DOAC reversal is indicated for emergencies in this beautiful set of icons and panels. If the DOAC is present in significant quantity based on the timing of when the patient last took it, or you actually have lab tests measured, then reversal is indicated to, abrogate the anticoagulant effect and achieve all of these things as Deb listed here below, with the bottom line of improving outcomes. Yes, next slide. This is a controversial result because it was surprising. These are the ANNEXA-I trial, the intracranial hemorrhage trial data. And it's interesting because it was a difficult study to perform, and I would refer you to the New England Journal where it was published. When you look at hemostatic efficacy and you look at hematoma expansion, Andexanet alpha really did a great job at having better hemostatic efficacy and decreased hematoma expansion. However, it was associated with an increased risk of thrombosis at 30 days. And so you see those right there. Jeb presented during this presentation some data that suggest that if you have less hematoma expansion, you actually have lower mortality. So how you juggle these different benefits versus risk for your patient is still yet to be determined with regard to the use of Andexanet for intracranial hemorrhage. Next slide. So patients who need surgery, there are no reversal agents approved for perioperative use. So if you can delay surgery, that is the ideal. The longer you get away from the last dose of DOAC, the better. There are limited data regarding hemostatic therapies. And so, we suggest using 4-factor PCC for the 10A inhibitor DOACs, but not robust data for surgery. Next slide. Our next speaker, Gabe Fontaine, discussed the different types of 4-factor PCCs available for reversal and hemostasis. Each has a unique composition. Valfaxar contains substantial amounts of heparin, so whether it actually is going to help in the bleeding patient is not really clear. And remember, we're not reversing DOACs, we're adding more prothrombotic substrate. And although they are not activated factors, which go around and actually cause thrombosis, it's not clear how much benefit are associated with these. Next slide, please. Well, there we go. So we can keep going. So Gabe discussed 2 future antithrombotic reversal agents, siraparantag and bentracimab. Next slide. Siraparantag is a small molecule that binds all of the factor 10A inhibitors and dabigatran, and appears to quickly and effectively reverse these agents. Bentracimab is a monoclonal antibody against ticagrelor, and this may be beneficial for patients who are on ticagrelor. It has such a long half-life that for patients who require surgery or have bleeding, it may be of benefit. Next slide. I'm going to turn this over now to Jori. Thanks very much.
Actually, it's going to turn it over to me.
Turn it over to Arthur.
Yeah, thank you so much, guys. So we're going to keep rocking here. On the next session, we're going to talk about what's called check yourself before you wreck yourself. And this was led by three speakers. We had Karina Meyer from a university in the Netherlands. We had Snehal Bhatt from Massachusetts College of Pharmacy, and then we had some goofy looking bald dude. So really just kind of summarizing what Karina taught us regarding coagulation, whether or not we should be doing coagulation testing for some of these drugs. Of course, for narrow therapeutic window drugs like heparin and vitamin K antagonists, certainly we should be testing those drugs. Not indicated really for the majority of patients prescribed low molecular weight heparin. And then she walked us through DOACs, recommending that it should be done for specific groups of patients at specific times with specific tests. Some of the examples of when we might engage in that were the setting of therapeutic failures, concerns about absorption like GI surgeries and that kind of thing. And if results just may impact a treatment decision. And the example she gave was, an apixaban patient comes in with an acute stroke being considered for thrombolysis. Would it be helpful to know if the apixaban was on board? Reversal in the setting of bleeding and urgent surgery was another consideration. Neil then walked us through yay or nay to anticoagulate. And he did so with a few cases. The first was a 49-year-old following with a DVT following a ski injury. And he just reminded us about kind of the basics of anticoagulation VTE treatment, with the initial treatment, primary treatment being that first 3 months, and then extended treatment beyond if therapy is considered long-term. And then he showed us here on the right a representation of the most common options, apixaban and rivaroxaban, for those three timelines. Second case is a 38-year-old with a subsegmental PE following a fall at a construction site. Reminded us that chest VTE guidelines allow for clinical surveillance for SPE, where when there's low risk for recurrent VTE and notably no proximal DVT present, the one thing that often gets missed is before you decide not to treat a subsegmental PE, you better scan the legs. And so there was some guidance here from the 2021 antithrombotic therapy for VTE disease specific to subsegmental PE. You see on the left imaging and clinical features, and on the right risk factors for recurrence. Third case was a 68-year-old prescribed apixaban for a history of atrial fibrillation, now needing a CABG. It was a peri-procedural case. He reminded us, using Jim Duquette's guidance here in chest, that this is in fact a high-risk procedure requiring full reversal of the apixaban, and he showed us a nice graphic to show what happens with the interruption window and how to manage that pre and post procedure. Then I went on to talk about common mistakes. The first common mistake that I chatted about was what I would call not differentiating clots. One of the tricks that the advantages of folks in our field is that we recognize that not all clots are the same. And we need to remember that most of the guidance out there when we're considering duration and are we going to even consider long-term therapy for a patient, that is almost completely exclusive to proximal low extremity DVT and PE. There's actually equipoise when it comes to isolated distal TVTs, to subsegmental PEs, and to superficial venous thromboses. And then additional guidance exists out there for other vascular beds like the upper extremity, like splanchnic and cerebral veins and so on. I also wanted to talk, while I was talking about not all clots are the same, is addressing this question that Gene kind of already mentioned about therapeutic failures. And I propose this kind of walkthrough and a consideration of if whether or not a therapeutic failure really is. So a patient shows up with a VTE while prescribed anticoagulant. We have to go all the way through, is it even really an acute clot, or is it something perhaps old? Or is it an unrelated event like an MI or something like that? What is there potential that the patient had reduced med exposure, things like non-adherence, dosing, some of the absorption concerns Karina mentioned, and then confirm that. And then if we even do confirm that it's a clot, then the question comes up about why. And some of this has already come up in this talk, but antiphospholipid syndrome, malignancy, maybe there's an anatomical situation like a thoracic outlet syndrome, May-Turner, and so on. Or sometimes it's just because diseases don't read textbooks. And then going on to the common mistake number 2, not differentiating risk factors. So we need to remember that we often think about provoked and unprovoked, but not all quote unquote provoked events are the same. The recurrence rates following a strongly surgically provoked clot versus those that are unprovoked is quite wide, but in the middle sits transient risk factors, so medical illness and those kinds of things. We also need to be thinking about ongoing risk factors. And then there's also this potency of risk factors that I like to show, got from Mike Strife, that put this together and has presented on this before. Every primary care doc known to man knows about factor V Leiden. Factor V Leiden in the big scheme of things is wimpy compared to other more significant thrombophilic concerns, with cancer being way up there, even above APS, and similar, or I should say second only kind of to surgery and trauma. So not all risk factors are the same. The third common mistake I addressed was giving antiplatelets too little attention. We've heard about some of this already, but really concomitant antiplatelet therapy should be avoided in most patients with mechanical heart valves, with the exception of the Onyx valve when you're using a lower range, most of the patients with stable CAD, PAD, and certainly in the setting of primary prevention. But if concomitant antiplatelet therapy cannot be avoided, we need not forget about the risk or about PPIs for gastroprotection. Try to protect folks as best as we can. And then we need to remember that aspirin has no role in AFib management, with that stance really firmed up in the most recent AFib guidelines. The fourth common mistake I said was having unrealistic expectations of anticoagulation therapy. This really gets to, gosh, my clot didn't go away. Shouldn't I stay on the blood thinner? I'll walk us through the acute, subacute, and chronic phase of VTE and kind of the natural progression and pathophysiology of what happens to clots. They either go away or the patient will get buried with them because they just kind of become scar tissue. And we need to understand that the goals of therapy, if we're considering long-term therapy, is not the clot you had, but the next clot you might have. And so we also discussed the timeline here, the initial phase of treatment, the primary treatment, and then the secondary treatment phase that goes along with VTE. So when I put all that together and think about, whether or not a patient should continue long-term therapy, I'm a relatively simple-minded fella and I need pictures. So if a guy walks in looking like this and develops a DVT in that setting, and after 3 to 6 months, he's back to running marathons, that would be a very provoked event with likely finite duration of therapy. If the poor fellow looks like this, and after 3 to 6 months of therapy, he's still gimping around like this, then we might consider extended therapy for ongoing risk factors. And if the patient who looks like this shows up with a blood clot, and then 3 to 6 months later, looks like the same guy, there's something going on. There's spidey senses should be tingling, and that guy likely needs lifelong anticoagulant therapy. The next session we jumped into was called Double Trouble. Jori May, Anita Rajashekar, and Ming Lim presented in this. Jori walked through really the 4 steps to answer the question, does a patient with a venous and arterial thrombosis require anticoagulation, antiplatelet therapy, or both? And really being very thoughtful about this. Step 1 being define the indication. I see very often, I don't know, the patient seems clotty, which is not very scientific. So arterial and venous, know your indications, know the guidance for the indications, know how we treat those. Step 2, assess the balance of thrombotic and bleeding risk. Step 3 being consider other interventions to minimize thrombotic and bleeding risk. And interestingly, some of the things that I often don't think about are statins in this setting. We've already heard it once today, but certainly weight loss statins, and then reduce the risk of bleeding with PPIs if the patient is at risk of GI bleeding. And then determine plan for the treatment and assessment. So using some of the examples in the step 1, some of the examples she gave where you maybe have primary, cardiovascular prevention, and then a patient gets an acute VTE or an acute coronary syndrome, and the setting of a patient with a historical unprovoked PE, or maybe the patient historically had a peripheral vascular event and now has cerebral venous thrombosis, and so on. Some of the examples she gave for how do we assess the balance of the risk that we might want to be thinking about. You have a patient who has a superficial venous thrombosis versus a patient who tries to die from a saddle PE. Those are 2 different things. Or a post-surgical VTE is one thing, but active cancer as an ongoing risk factor is another. And so just walking through these different steps. And step 3, consider other interventions. Initiate statin to reduce risk, as we talked about, weight loss and that kind of thing. And then thinking about determining the plan for treatment and reassessment. So how do we put all this together? So the examples here, the top one is a patient has an MI, maybe PCI 4 months ago, and is on DAPT because of that, but now shows up with a PE. How do we adjust the plan? We now need therapeutic DOACs. We're going to drop the aspirin, continue Plavix, and then beyond the 6-month mark, if we're going to continue long-term therapy, perhaps give a low-dose DOAC. The second example being a patient with a history of peripheral arterial disease, perhaps on dual pathway inhibition with low-dose Riva aspirin, suffers now a DVT. Now we got to think about therapeutic oral anticoagulant therapy. Perhaps we continue aspirin here in the short phase, but once we get to the 1-month mark, we drop that. And then after 3 months, perhaps it was a provoked DVT. Now we're back to dual pathway inhibition. Anita talked about liver disease, and she had this great graphic that really talks about the delicate balance of hemostasis in patients with cirrhosis. And I wish we had time to walk through the details. It's a very thoughtful graphic that covers really from stem to stern the issues that hepatic patients deal with. She talked a lot about whether or not we should give factors and things to make us feel better. Essentially, the answer is no in all of these settings with lots of explanations. You know, do we need to give FFP? Do we need to give platelets to make the platelets look prettier? Do we need to give vitamin K? You know, all of these scenarios, and she spent a good amount of time walking through why the answer to this is generally no. And then she talked about portal vein thrombosis, which is common in cirrhotics. Bleeding risk is not increased and maybe decreased with anticoagulation therapy. We need to remember that we can actually reduce the risk specifically of variceal bleeding by treating portal vein thrombosis. And she gave us some primary literature to address that as well. So the take-home points really from her session: these patients do have a rebalanced yet fragile hemostatic system. There's little evidence that by giving hemostatic, you know, by giving a number of factors to try to correct laboratory abnormalities, that it matters at all. We should reject INR as an isolated measure of bleeding risk and cirrhosis because there's more to the story. Use of arbitrary cutoffs like the platelets are less than 50,000, we should transfuse. Cirrhosis patients have prolonged bleeding tests are not auto-anticoagulated. We need to get rid of that term. Cirrhosis patients have an increased risk of AFib and VTE compared to the general population. Anticoagulation therapy for AFib and SVT reduces clinically important outcomes, and a nuanced approach to the complexity of coagulation with a greater appreciation for hypercoagulable aspects of cirrhosis is essential. Then Ming Lim, University of Utah, she covered some of the bleeding patients. Really, she went through a number of different teaching points. First being OAC-associated bleeding. Any bleeding caused from anticoagulant use needs further evaluation. You don't just blame the anticoagulant. I do see that one quite a bit. Teaching point number 2 for HIT, you got to calculate a 4T score using the peak platelet count after heparin was started. And patients do not have to be fully thrombocytopenic to earn points. Teaching point number 4 for she addressed ITP. In ITP, a thrombotic event can occur despite a very low platelet count. And so platelet count is not a reliable predictor of bleeding or thrombosis. About 10% of VTE occurs with platelets less than 30,000 and about 20% with platelets 30 to 50,000. So then she gave us this graphic, risk factors for thrombosis and ITP, reminding us that there are really patient-related factors, treatment-related factors, and then the ITP itself by creating hyperactive platelets and megakaryocytes and through some endothelial activation can contribute. Jori, bring us home.
All right. Well, I have 2 sessions that we'll try to fly through to make sure we don't miss anything. So teamwork makes the dream work. If Arthur can help us move forward, perfect. So we have perspectives from an obstetrician, a neurologist, and an interventional radiologist. And we got to start with our obstetrician, really highlighting the importance of VTE risk in pregnant patients. You can see here that the percent of pregnancy-related deaths related to thromboembolism is 10%. So this is a significant portion and concern for obstetricians and for us as coagulationists. And he highlighted some important pitfalls of multidisciplinary management for pregnant patients with thrombosis. And so this is really his take-home points, was the first to remember the kind of acuity and chaos that is the labor and delivery unit. And so oftentimes it's necessary to be more reactive to a crisis rather than being proactive. And so what he suggested to us as people who are providing guidance to the OBGYN teams is to really provide concrete plans. So instead of saying you can consider tranexamic acid, say give 1 gram of tranexamic acid at delivery. So be as concrete as possible and give advice for possible complications that you might anticipate. The challenge can be sometimes, or a pitfall of not knowing the local context. So try to combat that by really considering a patient's geographic distance to access care, the OBGYN practice type, patient preference, and thinking through those things. And then lastly, unplanned or undesired pregnancy is to really make sure that we're being proactive about talking to our patients about contraception and offering to that. Even as anticoagulation providers, I frequently bring this up with my patients. And I want to highlight the new rapid resource on anticoagulation use in menstruating people, which gives great guidance for selecting contraceptive management, either for control of menstrual bleeding or contraception in people with increased VTE risk or on anticoagulation. So be sure to check that out. For cerebral venous sinus thrombosis, so this was covered by our vascular neurologist, Dr. Talia Field. She talked about when to start oral anticoagulation in these patients. And basically, it's dependent on how the patient is doing, right? So when can we start it? It really depends if the patient has depressed or worsening loss of consciousness, focal deficits, or uncontrolled seizures. That's probably not the time to start. So what does their follow-up imaging look like? They're basically thinking about oral anticoagulation only if imaging is stable. So they don't make that transition if they're seeing imaging 24 to 48 hours later with mass effect, potential need for decompression, worsening clot burden. So really relying on their imaging to find stability in order to make that transition. When to stop oral anticoagulation, the same rules as other sites of VTE. So we think about primary oral anticoagulation for 3 to 12 months, shorter if there's a clear transient provoking factor, or if the clot is completely gone away, or if there are other active bleeding issues. A question that I often get is, does it matter if there's recanalization, if that area of clot has opened up and there's a pathway for flow? She discussed this in a really nuanced and important way that we have limited literature here. It's mostly retrospective, it's heterogeneous, but recanalization may be associated with worse outcome, no recanalization, excuse me. So if it doesn't open up, can be associated with worse outcomes, but the benefit is primarily in that very early phase. So hard to know if recanalization is something we need to look for in part of that decision making for whether to start or stop anticoagulation. She also talked about antithrombotic therapy after intracranial hemorrhage. This is a common diagnostic challenge. How do we know when we can restart anticoagulation? And she emphasized again here, imaging is really critical for risk stratification. So who's at high risk for having a repeat bleed or versus who is not? And emphasizing too, we're always focused on the anticoagulation, but we've got to control their blood pressure, right? Hypertension is a significant risk factor for rebleeding. But in individuals with AFib and a history of lobar hemorrhage, or this finding of cortical superficial siderosis, which is something that wasn't really on my list of things that I look for in imaging as a risk of recurrent bleeding, these are the people that they might be more concerned about restarting anticoagulation. So lobar hemorrhage, or this finding that you see on image here, this cortical superficial siderosis. And that ultimately, if we are restarting, we're waiting a reasonable amount of time to ensure blood pressure control before restarting anticoagulation. And lastly, from our interventional radiologists, I was really hoping for a definitive answer on what to do with antithrombotic therapy after venous stent placement. But the ultimate take home is that there is absolutely no consensus. So he presented a nice reference here that kind of presents a case of a patient who had a venous stent placed. And you can see here, it was a survey of 106 experts, and everybody is saying something different. So some say anticoagulation with low molecular weight heparin first, and then oral anticoagulant. Some talk about oral anticoagulation for a period of time. Some say lifetime, some add antiplatelet therapy. So unfortunately, this is really provider specific. But one thing that he did mention was some of the things that they look at from an interventional radiologist perspective for selecting antithrombotic therapy after procedures. Importantly, if they're looking at catheter-directed therapy alone with no stent placement, this is limited in anticoagulation because it's really just related to the damage to the endothelium with the procedure. If they are doing mechanical thrombectomy or angioplasty, this is maybe more prothrombotic, increased endothelial damage. And they look at things like the anatomy itself. They're looking at the amount of inflow, if there's the presence of stenosis or occlusion, that might increase thrombotic risk, or if there isn't great flow after intervention, and then how many stents they're putting in and how extensive that might be. And Arthur, I think we should probably skip over this last section because I want to be respectful of everybody's time. Another great session, but just a nice reminder that you got to come to the conference to see all the good stuff. But Arthur, do you want to close us out?
Absolutely, Jori. Sorry that we didn't get through all of that. That was a whole lot to cover. I want to thank again the presenters here. Did an excellent job of trying to herd all of those cats and try to cover a lot of material. A couple of quick announcements as we ended up for today. Just a reminder about AC University. You know, the Anticoagulation Forum is adding new content to AC University, so stay tuned over the next couple of months for new accredited educational content. And you know what you just saw was really just a drop in the bucket of what was presented at the Anticoagulation Forum. We're going to be putting out some conference bundles for purchase. So this is going to be part of the AC University's ability to purchase the most popular sessions from the conference. So if you weren't able to go, stay tuned. We'll be able to have that option there. And then we're going to be having the next webinar for June is emerging anticoagulants and reversal agents. What's next in the pipeline? You saw a little bit from Deb Siegel and Gabe Fontaine's chat. We'll bring on some speakers, including Gabe, to do a dedicated webinar on this topic on emerging anticoagulants and reversal agents. So having said all of that, I appreciate all of your time. Thank you all again to my speakers. Thank you, Anticoagulation Forum, for hosting this event, and we'll see you next time.